Hello, everyone out there, wherever you are. We have a really exciting program tonight that I'm being very selfish about because I'm going to probably learn more after this program than any of you are put together. We're going to be talking about a topic that's become all important, not just in breast cancer, but in virtually all subsets of cancer care, whether it's hematologic, oncologic, and certainly transcending into other areas of medicine. It's something that I would have never dreamt of when I started, and I'm going to date myself, over 35 years ago, when we talked about the immune system and cancer and white cells and red cells, and really not ever understanding how important the heterogeneity of our DNA is. You know, breast cancer is a lie. It's not one disease. It is multiple diseases under one umbrella, and you could have the same tumor type, the same size tumor, the same profile as we've identified it over years and years, whether it's estrogen positive or estrogen negative or HER2/neu positive or triple negative. And it can behave very differently in two different women, two different patients, because of the soil that it is growing in or wanting to grow in, and what we as individuals bring to the breast cancer arena. Tonight we have with us two wonderful women, and one you've all become familiar with. It's Colleen Murray. There she is, waving hello, a nurse practitioner extraordinaire, who is always at my side and has really become a loved member of the practice, devotes herself to patients on an individual basis, almost as if she's targeted therapy, understands their needs, and knowing that everybody's needs are different, everybody's language is different, everybody's breast cancer is different, and more importantly, understands their fears, because we all present with our fear and deal with our fear, harbor our fear, and worry about our fear very differently. Thank you, Colleen, for being who you are. I am pleased, excited to introduce Dr. Jamie Holloway, who I've known about, but actually got to know personally just this recent December at the San Antonio Breast Cancer Symposium, where she was moderating a panel of 3 speakers, and I was really proud to be one of those 3, in order to allow fellows who were planning to move into the oncology arena, whether it was liquid or solid, to gather information of what makes a medical oncologist tick, whether it be somebody who's in research, in industry, in a tertiary academic practice, or a community practice. What is it about it that brings us to that understanding of that's where we want to be? Jamie Holloway joined Caris Life Sciences in April 2019 as the Area Vice President of the Molecular Science Liaison. She now leads a team of field-based PhD-trained scientists who act as a resource for any technical, clinical, or research discussion with oncologists in both the community and academic settings. I know because I'm one of them. Prior to joining Caris, Jamie worked in patient engagement and built an extensive network within cancer patient advocacy communities. She was a part of the patient engagement team at Cure Forward, Science 37, and the Metastatic Breast Cancer Project at the Broad Institute. She's an active volunteer, and by the end of these 50 minutes, you're going to understand why and how lucky we are that she is, having served on high-level committees with AACR, ASCO, Friends of Cancer Research, and the NCCN, the one that stamps the approval of how we're going to move forward with patient care, meeting all the appropriate guidelines. Dr. Holloway earned her bachelor's degree in biochemistry from the University of Illinois and her PhD in tumor biology, just saying that is scary, from Georgetown University, where she studied the interaction of growth factor signaling and estrogen receptor expression in breast cancer. She lives in Arlington, Virginia with her husband and her 2 teenage children. And I just want to say that I'm Maria Theodoulou. I've been in breast cancer care, clinical trials, patient advocacy, and caring for patients, running symposiums, survivorship programs like this one for many decades. And I am excited that this virtual program that comes on a monthly basis has become popular. And we're going to move forward. So, given all of those introductions, hello, Jamie. Hi, Colleen. Jamie, I've got to ask you, we've titled this presentation as Precision Medicine, and what it means to the patient, what it means to the caregiver. What does it mean? What is precision medicine?
So I think most people sort of define precision medicine as getting the right treatment to the right patient at the right time. It's sort of a very broad definition. When we think about it more specifically, it's about looking at the very specific makeup of that one individual's tumor and thinking about how we can take advantage of the way it's growing to stop it. It used to be that we sort of bucketed tumors by organ type, and that was about it. And you got right sometimes, but to look more specifically at the individual tumor, as you said, they're not all the same. That helps us to increase our odds of treating the cancers effectively.
For the past decade and a half, we've been using the term targeted medicine, targeting therapy, and it's been in multiple lectures, multiple literature. Is that really any different than precision medicine, or are we just refining the term?
So I think we're sort of refining the term. When I think of targeted therapy, I think of the drug that has a target that's in the tumor, and that drug acts on that one target. Precision medicine is maybe a little bit more broad because it takes into account the whole patient and sort of tailoring treatment for the whole patient. So I would definitely argue, having spent a lot of time in the patient community, there are times when considering things like side effects and quality of life are very important. And it's more than about just the target, but it's about sort of treating the whole patient in an appropriate way. But generally, as you say, when we talk about them, they're kind of interchangeable.
I remember about 15, 20 years ago when I started lecturing on molecular biology in breast cancer, I would start off with a term that I will say that I'm not the author of, but I would try to define to lay audiences or fellows or residents, medical students, and physicians who were in practice, that if we were to take the DNA from an individual cell in a particular human being, take all of that DNA out of all of those chromosomes and really stretch it out and stretch it out and stretch it out. And we looked at all of those exons and put them head to tail, that we would have several round trips from the Earth to the sun. And it always sobered me that, boy, something could go wrong in any one of those genes, this vast array of genes, and really propel someone's individual cell to go awry. And at what point does the immune system start being our friend and start being more friendly to that cell? And now we have something that's proliferating and growing. So for me, it's been humbling to be able to take a piece of a patient's tumor and look at some of those genes in a molecular assay. And how many genes do we look at when we run a profile, let's say with Caris?
So when we run a profile with Caris, we're actually looking at every single gene in the human body. So we're looking at over 20,000 genes. We look super close at over 700 of those genes. So we have sort of a dual experiment going on where we're looking, overall at all of the genes and super close at more than 700, where we know that they have some indication that they might be helpful to know about in cancer. So there are some genes that are more likely to contribute to cancer, and those are the ones where we look extra close.
And I know that when I'm looking at molecular profiling for an individual patient, I'm also looking at those genes that may make a difference in what's available for treatment for those patients, whether it's in the standard community setting or whether it's on a clinical research setting where I would refer a patient to a tertiary center to see if they would fit a study for that particular gene abnormality. Right now, we've been looking at the molecular profiling of patients with advanced disease. We know that sometimes advanced disease may look very different than their early presentation, that there are mutations. There may be more mutations in the later setting than in the early setting. And so important to be able to understand that there may have been a shift. There may have been a change, and we may have to start viewing that cancer in that specific patient very differently. And I think what is hard for some to understand, and is that we can never stop evaluating the changing world of cancer, and certainly the changing world of an individual patient's cancer within their environment. Do you foresee, and this is just conjecture and I don't hold you to it, and this is a public forum, we may both be out of jobs at the end of this presentation, ouch. Do you foresee it coming into an earlier setting at initial diagnosis, where now we certainly have successes with what we know, but there's so much room for more?
So, I mean, breast cancer is kind of, it's a poster child for molecular biology sort of overall, because we've been classifying breast cancer subtypes by protein expression for decades, right? We've been looking at estrogen receptor expression, HER2 expression, to at least classify it into certain groups. And breast cancer has been getting targeted treatment for a very long time because we're using things like tamoxifen and the aromatase inhibitors now, and Herceptin, and all of the other HER2 targeting drugs that are now available. So it's in the early setting at the protein level, and taking it to the DNA level is something that's already happening in other tumor types. So if we look at lung cancer now, lung cancer has lots of drugs that target specific DNA mutations. They started out in the late stage setting because that's where you could see a bigger impact, and that's where it's easier to get clinical trial agents sort of brought in. But they are now approved in an earlier stage setting, and some of them are even now in clinical trials in stage 1A disease, so very small localized disease. So that's what we're seeing in lung cancer, which sort of led the charge for targeting DNA aberrations, DNA changes. So I don't think it's out of the realm of possibility that we're going to see that happen in other tumor types. We're starting to see it become more important in endometrial cancer, for example, to know which patients maybe need more therapy and which patients can do really well with less therapy. And so I think that that's something that we'll see continue. Breast cancer is probably not quite on the cusp like some other tumor types, but I think, we're going to come to a place where people are going to see it as very important early and often. And the often part is because if the chemotherapy that you were giving to a patient or the targeted therapy was killing off every single cell, then they wouldn't have progression. But if you have progression, that means that that cell figured out a way around the drug. Mm-hmm. And so then what we need to do is figure out what was that way around the drug, and can we target that new way? And so we're always looking for what's the change and how can we take advantage of that change to try to slow down the growth and to hopefully stop the growth of the tumor.
Right. And, even in the protein expression setting, it was when we really understood the nuclear expression and the cell membrane expression of some of the growth factors. And, the charge is always in late disease. You want to take a tumor that measures this much, treat it, get it to this, and maybe one day have this and say, wow, this worked in a setting where there were so many cells. And if you look at my pinky nail, you need 1 billion cells, that's 9 zeros, to make a tumor this size. Then maybe we should take this and bring it into the earliest setting so we don't have to get to the point where we have this. Well, we have done that on so many levels, and we have impacted on patient survival and decrease in recurrences in so many settings. Have we hit 100%? Nope. We also don't walk on water. We get wet a lot. But I'm hoping that as we move forward and we continue to understand what works in the late setting, what's safe to bring in the earlier setting with a narrow window of acceptance of side effects, whether short-term or long-term, then maybe we'll start identifying, as they did in lung cancer and endometrial cancer, some additional information that maybe will let us float on top of water a little bit longer. Colleen, you've always been such an advocate of having patients understand what their own tumor biology is all about. And I can tell you that we have patients that are diagnosed with in situ breast cancer when it's precancerous that come in and ask for molecular profiling. We have to explain where that works and why it wouldn't or whatever. But Colleen, for you, there's a passion about what you do that really transcends so many practitioners. And I know that you have a story that you've told on so many levels, so many different times. And why would this molecular profiling, understanding the inner workings of a particular specific patient's particular specific breast cancer, be important? What say you about the patients that you talk to? What say you from you?
Yeah, I mean, I think, Dr. Holloway's point at the very beginning of our conversation, this is so important for us because sometimes the reports will come back to us and we might see a drug that maybe we really haven't totally considered for a patient in the later stages. And, I think, as you had said, talking to a patient about the side effect profile and their quality of life and things that are important to them is most important. We try to, find the best drug for the patient with the least side effects, the best we can. And I think doing the molecular studies for these patients has really kind of geared us a little bit to factor in those things for the patient. Does she, want an oral therapy? Does she want to be able to do the things with her family or travel, or and then make the adjustments that we need to best accommodate the patient with the best treatment?
Well, the first tenet of patient care is understanding the goals
Yeah.
of our therapy, and not just the goals of the practitioner who is going to discuss all the science and all the possibilities, but what the goals of the patient is.
Sure.
And when we talk about stage 4 breast cancer, we need to talk about the bulk of the disease. We need to talk about the symptoms that they may have or not have. We need to talk about how that might take them away from their family or their goals to be very, very aggressive so they can be there for their family, longer down the line. There are so many variables. And I truly, truly believe that by being able to have a discussion with a patient and looking at all those variables, and not by any means wanting to tell this audience or any audience that if we understand or if we exact a particular target by doing precision medicine, that it's going to be a game changer 100% across the way. What it does is allow us to think about something that we might not have thought before. Somebody who is estrogen positive, but not responding to an anti-estrogen therapy in the early setting, who has a quick recurrence after their adjuvant endocrine therapy, and perhaps find out that they have a mutation that may not lend itself to a particular anti-estrogen, but maybe to an alternative anti-estrogen. it breaks down doorways and allow us not to waste time. Jamie, I'm going to throw this at you. You're in front of patient audiences and advocacy groups. You hear their questions. They reach out to you for information. You clearly have a sophisticated, complex subspecialty that you have become an expert in, and I bow down to you on that level. Yes, yes, yes. And I'm going to throw this at you. What do you think are the patient's concerns when they come to an event that you're speaking to, or when you appear at a group that wants more information, or maybe to reaffirm what they're already doing? What is your interaction on that level?
So, I mean, I think, you both have said it very well. The individual patient has an individual goal, and I have met the patients who will go through any terrible side effects necessary, and it doesn't matter how awful they feel because they've got little kids at home and they want to see those little kids get older. I have also spoken with ladies with metastatic disease who say, if I can't work, then this drug is not going to work for me because I need to sort of maintain whatever sort of normal life I can. Maybe I need to maintain my health insurance. And so if I can't work, if the drug is going to make me feel that bad, then that's not the right one for me. So I think the first thing is really thinking about what each individual's goal is. A lot of times in the metastatic setting, it's very important for them not only to have they want the tumors to shrink, but they also want just maybe to not have any new lesions occur, right? And so it's thinking about those specific things when you're speaking to people. But I think the place that I find a lot of patients really struggle is when they get presented with options from an oncologist. And as a patient, you sort of think this person went to medical school and they did a fellowship and they've been practicing for 10 or 15 or 20 or 30 plus years. And they don't know what to do, but they think I know what to do. That doesn't make a lot of sense to a patient. And so, the communication that I've had on an individual level at the coffee shop, I have this coffee shop down the street where I feel like it's a second office. I've done lots of conversations there where we just sort of talk through, why is the doctor giving you a choice here? And it's really because there's not a better option, but there's also not a bad option. And so taking the time to think through the fact that you've looked under all of the stones, and you've now got all of the information you can, and these are what you would think about as far as decision making. And a lot of times when there's two options, one of the decision points is one drug might be easier on me than the other, and we don't know which one until we try. And so, that's what when I think of the molecular profiles, a lot of times, especially the really, really empowered patients who are reading about trials and targeted therapies, they get disappointed when they get a report that has no exciting target on it. And the people that I work with at Caris, they get disappointed when they have to send a report back to a doctor and there's nothing exciting on it. And what I've been really trying to impress upon them is that an empty report is not uninformative. And what that means is you've looked under all the stones, you haven't missed anything,
No
and
surprise.
now your best option is the standard of care. And, I think that that's so important for people to not be disappointed when, as a breast cancer patient, you maybe don't see the PIK3CA mutation, or, you've read about NTRK inhibitors, and there are sometimes those NTRK fusions in breast cancer, and those have great responses to therapy. And to not find that is disappointing. But, if you're a triple negative patient, you didn't find any targetable treatments, but actually early stage triple negative patients respond pretty well to just run of the mill nasty chemo. And so I think it's really important to not focus on being disappointed by not having something that seems exciting, but knowing you've looked everywhere and this option is the best option.
I have to say, you trigger something that I hear a lot. And when a patient is diagnosed with a triple negative breast cancer, they feel like they have to come in and in an early setting, I'm not talking about metastatic disease,
Right.
that they need to come in with a calendar and watch the clock, because it's such a quote unquote terrible disease that they know that next month it's going to come back, or they have someone that they're on the internet chat site that had their disease recur, and yet, if we look at triple negative breast cancer, knowing that it's not one entity, again, it's very different within individual hosts. And I think an example of that is, and Colleen has heard me say this, so don't be too bored by what I'm going to say. If I had a packet of seeds and I shared them amongst the three of us, and I said, let's go out to our gardens and get those seeds in the soil, in Colleen's garden, nothing may happen. The pH, the water level, the temperature, the wind, is just not right for that particular seed to take off. In Jamie's garden, we have seeds that germinate, but they don't have the potential to break through the soil. And then you get Maria's garden, which has all of the appropriate requirements for that seed to become a plant, a stalk, a seed head, and spread its seeds for whatever the reason is where my particular soil is. So you could have the same diagnosis in 3 different patients and it will behave differently. Yet we are seeing now, with understanding and more understanding of triple negative breast cancer, that yes, chemotherapy can work. And by using it early on, often in a pre-surgical arena, we can get good outcomes. And I have a patient, and now I've been gone from Sloan Kettering for 7 years, but when I left, I was saying goodbye to one of my women who was diagnosed with a triple negative breast cancer, triple negative based on her ER, PR, and HER2 status that was diagnosed almost 20 years prior to my leaving. She had 22 positive lymph nodes. We weren't doing neoadjuvant then. I treated her with dose-dense therapy, which we were really at the forefront at my former institution. And there she was, 20 plus years later, tearfully saying goodbye to me. She had already changed 2 husbands, and we talked about shoes for the remainder of the session. So it's not the disease that everybody expects it to be. All right. And yes, can there be somebody who relapses quickly? Yes, but those numbers are becoming smaller and smaller. And I think hearing good stories is important also. I find that many patients who have bad stories have more time on their hands. And I don't say that as a disservice. I say that with a sadness because of where their disease might have taken them. But we need, for a lot of our early patients, to talk about the good stories, not just share the bad stories. And that's what I hope for every single day. I hope for those stories to be so many that I'm out of work in the next few years. And that will be a day to celebrate when all the medical oncologists are on the unemployment line fighting for who's going to get their next paycheck. Yes. Jamie, I'm going to throw this one at you because you've advocated for patients and you've shared stories, and I think this is the right time to share that story. So I'm putting you on the spot here, darling.
Perfect. Well, it is my hope that in another 10 years that my oncologist will be saying such kind things about me as you've just shared about your patient. And
well, hopefully you won't have a second husband. Yeah.
Talk about shoes, but hopefully it will just be that same husband, right? Yeah. So about, well, a little over 10 years ago, I was actually diagnosed with triple negative breast cancer. It was stage 2A, so bigger, but lymph node negative. So unlike the patient that you talked about, and it was at the end of just doing dose-dense ACT before, bringing in platinum or, immunotherapy, which is obviously something that a triple negative patient would do now. But we did do neoadjuvant chemotherapy. As a scientist, that was really attractive to me because I was like my own N of 1 petri dish, because I knew where the tumor was and we were going to treat it, and then we were going to take it out, and we were going to see what happened. And so
And you would find out what worked.
exactly. And so the idea at that time was, if we do surgery after the chemotherapy and there's tumor left, then we do something else. And that's where I would have gone to a platinum at that point for the residual disease. But when we did the surgery, I had a complete response. So there was nothing left but a little bit of scar tissue and the marker from the biopsy. So I was done, and I had my surgery. That was over 10 years ago, and I've been without evidence of disease since. And one of the things that I'm so excited about for the future of early stage breast cancer is being able to monitor that early post-treatment early stage patient, because as I'm sure you know, Maria, the ASCO guidelines, my oncologist, bless her heart, printed them out for me. The ASCO guidelines that said there's no additional screening after. You just come in once or twice a year. We ask you some questions, but if you don't have any symptoms, there's no subsequent screening. So one of the cool things that we're doing with molecular analysis right now is looking at DNA in the blood to see if we can see for any signal that there's still cancer in that person's body, to maybe be able to treat it sooner. Because as you said, triple negative patients watch the clock like crazy because you expect an early recurrence. If you get a little bit further out, then you're in pretty good shape. But, those first few years, there were a lot of extra scans of anything that maybe hurt a little bit or a little bit longer than it should, or that I thought it should. It was definitely a source of anxiety. And so I
trust your body again. And at that point, you hadn't trusted your body because it
right.
had betrayed you on some level.
Exactly. It had betrayed me on a major level. And so, I think that the ability to use the molecular features of a tumor to track it and see, did we get it all? Is there even a chance that there's still some floating around in there that we should stop early, is really exciting. But after having gone through that, it really did give me the opportunity to be able to speak with a little bit more empathy and a little bit more authority when it came to talking with patients, because I understood a lot more of what they went through. And while I did not go through treatment for metastatic breast cancer, so there's a lot of stuff that I don't understand well, but I made so many wonderful friends in that community, and I try really hard to listen more than I talk. Today, all evidence to the contrary, but I tried to listen a lot to those individuals and kind of hear the things that were concerning for them, so that I could maybe help explain the science a little better, and just, again, giving them the confidence. I'm never going to change what somebody's doctor tells them to do, but I want them to understand why, those are the decision points that they have.
That was very generous of you. And I will tell you that 10 years ago, when you were diagnosed, and even going back 20 years and longer, studies were done on multiple levels trying to figure out, would serial scanning be important? What were the first indicators of a recurrence? Do we have to get, now we have PET scans and so on. Do we do those every year? And really, some of the older studies, and I'm sure one of the studies that your oncologist had been trained on or was part of, was that we knew that the first thing was conversation, what a patient brought into the arena, what their complaint is, what new symptom they may have. That was the number one reason for looking for metastatic disease. Number two, physical exam. Number three, blood work. And number four, it was imaging. Now, I will admit that our imaging is much more sophisticated today, and the interrogation of our bodies is much more amenable to minimal disease burden that may be in other organs. But for a long time, patients who had stage 1 or stage 2 triple negative breast cancer, I would also say there's no reason for re-imaging on a regular basis. We might do more harm with the radiation exposure. I will admit that. Stage 3 patients, so maybe a different story. I'll image those patients for the first 2 to 3 years and then stop. The one thing about what we're seeing with the maturity of our studies in the triple negative setting is that, we used to say, boy, 5 years is magical. Dr. T, I just made my 5-year anniversary. I'm going to throw a huge catered party. Will you come? And I would go home and never wanting to burst a patient's bubble, because those bubbles are so important. I would think, where did that 5 years ever come from? And when we think about it, the 5 years came from because that's how long studies were funded in the old days.
Yeah.
So once a study was over and it closed at 5 years median follow-up, then we said, hey, and everybody thought that was it. Let me make 5 years and I'm going to be good for the rest of my life. And now we know that different subtypes of breast cancer, you know, where we're following them for 10 years and 15 years and longer, we may see differences in behaviors of the disease. And again, it's not all for one. We, just like with the little seeds in the garden, the disease will behave differently in the host that it's growing in. But we're getting smarter. So I really want to throw this out, liquid biopsies. Okay, let's talk to the audience about what that means. What does a liquid biopsy mean?
So a liquid biopsy, the way we normally talk about it in cancer, is looking for evidence of cancer in the blood. Most of the tests that are available right now look for little pieces of DNA that have been expelled from cells that are dying. So when a cell dies, it kind of just explodes and you end up with little pieces of tumor DNA in the blood. And so most of the tests now that are available will look for those little pieces of tumor DNA floating around in the blood. And then we sequence those, looking for those specific mutations that maybe help us to make a treatment decision. So in breast cancer, if you're sequencing the blood, you're probably looking for a PIK3CA mutation or maybe an ESR1 mutation that would explain resistance to hormonal therapy. And both of those mutations now have a drug that's tied to them. So if you have a PIK3CA mutation, you are more likely to respond to alpelisib, which I can't remember the brand name anymore. I only remember the really hard names.
Pickray.
Pickray, yes, Pickray. And you know, the ESR1 mutation is going to be targetable now with elacestrant, or you're going to respond better to that one than other hormonal therapy. So that's what we're looking.
Just approved. It was just approved like a week and a half ago. Yeah.
Right. So that's what you're looking for. But what we're trying to figure out at Caris is how to look not only at the cells that are dying, but to look at evidence of cancer molecules from living cells. So DNA, I'll do a really quick molecular biology primer. So DNA is like the building block of all your cells. It's like the blueprint, right? And then DNA is transcribed into RNA. And then RNA is translated into protein, and protein is like what does the work in the cell. So it turns out that you can see evidence of these mutations in the RNA, and RNA is actually actively exported from living cells. So there are some limitations for standard liquid biopsies where if you're going to measure the DNA that comes from cells that are dying, that's from a tumor that's growing like so much that it can't keep up, and then the cells die and explode. But if you have a tumor that's just kind of like cruising along, it's maybe not going to have so many of those dying cells. So you're not going to see so many pieces of little DNA chunks floating around in the blood. So what we're trying to do is we're trying to figure out how to look at that RNA that comes out of the living cells that's actively exported to maybe get a hint of the mutations that are driving that tumor even before it's totally out of control. So right now, especially in the breast cancer setting, liquid biopsy is going to be most useful in patients who have progressive disease, and maybe a biopsy of the tumor tissue is not possible. Like if you're an ER positive patient and you have bone mets, right? It's not going to be a great option to do a bone biopsy. And especially if you have that option of just looking in the blood, that's way easier. So, you know, the liquid biopsy gives you the ability to sort of peek at what's going on in the tumor without actually having to cut into the tumor to get that tissue.
You know, that's a great way to have explained it. Obviously, you're a pro at explaining this, but knowing that, again, not everything is the same for every patient, and we need to know where to use the science and why we're using the science, and when to interfere with what we're doing, when to hold steady with what we're doing. And I think that is an ever-growing, expanding notion as we become more eloquent in the development of our therapies. Knowing that we have certain therapies, we have certain boxes of therapy, and to know when to reach into that box. All right, because there is a box there, and it's either going to be useful for that patient or it may not be useful for that patient. And to go back to what you said, Jamie, early on when we first started this program, I can't believe we're already 10 minutes into finishing, that finding the box that's right for the patient can be a very good thing, and not finding the box can also be a good thing. Can also be a good thing. You know, the one thing about breast cancer is now with other cancers catching up, we've always had a multitude of treatments. And it's always been, you know, let's just, in the advanced setting, let's just keep moving forward until we find that right button that is the win. And to go to what Colleen said earlier, not making the patient so sick or causing side effects where we can't use that new treatment down the line. So the balance of exploding therapies, exploding science, and what we can do has become so ever complex and difficult, but every patient is worth our hitting our heads against the wall about.
There is a question if you want to hear, Jamie.
Yeah.
Okay, great. Someone asked us, how are liquid biopsies obtained?
So it's just a blood draw. You know, it's either usually 1 or 2 10 ml tubes of whole blood that is sent to a company, and they can be taken in the office. Also, a lot of companies have the ability to do mobile phlebotomy. So if your doctor wants to get a liquid biopsy, they can arrange to have someone come to your home and draw the blood as well.
Great, thank you.
Great. So thank you, Colleen, for doing that. I would have never looked at the chat room. You've already earned your pay on this.
Oh, great, great.
Oh, we don't get paid for this. So, you know, I think where we have to be very careful is not at this point in time, because I still consider it early in the field, not abusing the science in areas that we know not where it's going to take us by way of helping the patient. But I am a believer in banking information early on. You know, I like getting my information really early, and hopefully not just with archival tissue, although, you know, oftentimes we do use that. And sometimes we may have to biopsy again after a treatment failure to see, are we still dealing with that same cell? Because tumors are made up of something called a heterogeneous population. So I may have this cancer cell that's responding to my treatment, but next door to it, there's one that is missing the target or not receiving the treatment as elegantly and may survive. I need to know about the second one. So sometimes a patient will be asked to go back for a biopsy to be able to understand some of the proteins that may be changing on that tumor surface or within the nuclear department. Yet it would be so wonderful to be able to get all that information with just a blood draw, wouldn't it? and not have
Yeah,
to.
and I mean, I think we're getting to a point where they can be so much more helpful. It's still important to note, though, that if you get a negative on a liquid biopsy, so for example, if you're looking for that,
I would get a
PI3
tissue
kinase,
biopsy. Yeah.
if you get nothing, you really need to check in tissue too, because I heard someone say it once, and I think it's so apt. He said it's like looking for a needle in a haystack, and if you find the needle, then it's a needle. But if you don't find the needle in a haystack, that doesn't mean it's not there. It just means you didn't find it.
I
and
agree.
so so if you get the needle, then by all means you run with it, you treat the patient with the appropriate therapy. But if you don't find the needle, you maybe need to go back to the solid tissue just to make sure, because liquid biopsies are just not quite at a point with sensitivity that they're picking up everything.
So we have to stay friendly with our interventional radiologists and our colleagues in the surgical department. Absolutely.
Yes, for sure.
We have a couple of other questions,
Okay.
and they're actually kind of related to each other. Someone asked, is liquid biopsy something that can be useful for HER2 positive survivors? And to back on that question, someone else said, any new HER2 therapies coming out?
So HER2 is a protein that's expressed on a cancer cell. So you can't see that in the blood. So if you're trying to just monitor for level of HER2 protein, then you really have to have a tissue biopsy, and the liquid biopsy is not going to help.
Now, just let me interject here that we're talking about advanced disease.
Correct.
At this point in time,
Stage
we're
4.
talking about stage 4 disease. This is not the early HER2 new positive breast cancer diagnosis that has, really good prognosis and does well with early treatment, or even those patients that go on to neoadjuvant therapy. We're talking about stage 4 in this HER2 setting, please. And then I'll add into the treatment profile. Go ahead, Jamie.
Yeah, so really liquid biopsy right now is exclusively being used in the late stage advanced metastatic cancer setting. So that's a really good distinction. There are lots of new HER2 targeted therapies. I'm sure she could talk about them. It's really exciting for us, but definitely I'm sure something I would love to hear from you is just even thinking about the adverse events or the side effects, right, that come with some of these drugs as you think about how to order them.
So obviously, whether it's in the early setting or the late setting, it's the same what the goals of therapy are, knowing that there's a target we're going to go after, and knowing what drugs are available and in what setting and what has reached the clinical trial maturity to appropriate that drug for that setting. I'm of an era where there was no anti-HER2 new therapy. I'm of an era where we knew that the HER2 new protein existed. We knew it as a growth factor, didn't know what to do with it. I'm of an era where I was the principal investigator of the very early trials in the 1990s, where we randomized patients to receive anti-HER2 new therapy in just one monoclonal antibody form versus none. And am excited, number one, to be alive in 2023, to be able to say that over 3 decades have passed, and where patients were succumbing to their disease, we have more survivors than patients succumbing. What is incredible is the evolution of what we're seeing in the advanced setting that we're now bringing into an earlier setting, so we don't have to deal with the advanced setting. And that for me is huge. And yes, there are new drugs that are out there. It all depends on where the patient is with their drug therapy. There are new drugs in the metastatic setting, multiple. There are drugs that have been moved out from early stage 4 settings and replaced by others. I don't think this is the forum to talk about individual drugs, because I think it would be more confusing with only a few minutes left. But it's incredible how quickly it's all moving, how the landscape is exploding in its advancement, which means that we have more available in the advanced setting, where patients can be treated and treatment moving on to another treatment with progression and another treatment. I have patients who are doing well 25 years later with stage 4 breast cancer in their lungs or their liver or their bones, who are doing great after being introduced with only one regimen of anti-HER2 therapy when they were diagnosed. I have others that develop resistance, and we have to figure out which cell is it that may be the culprit. Those treatments are now entering studies in an earlier setting. That for me is astounding. And it's not a regret for the patient who was diagnosed 2 years ago or 5 years ago. It's a celebration of those that are going to be diagnosed 2 years from now or 5 years from now. I could start naming drugs like tucatinib and HER2. I could start naming drugs that are being used in combination. We can start naming new conjugates that go after the apoptotic mechanism that sometimes goes to sleep apoptosis, meaning natural cell death. Because when a cell becomes abnormal and it starts to turn into its cancerous counterpart, that cell should die. It's not a normal cell. It should die. And yet something is triggered inside that cell that tells it not to die, targeting treatments to those pathways. So in the anti-HER2 arena, I think we're going to have a whole session on that. So Colleen, remind me, maybe
I will.
in May. I'm very, very optimistic in that arena. Remember from whence I come and from where I am and from where I look forward. We've gotten to the point where in our psychopathology as medical oncologists, there was a time 10 years ago where we wanted our patients to be diagnosed with HER2 positive disease because we had such an outstanding outcomes in our clinical trials. That's just our craziness, wanting to have everything to do for our patients. But it's going to continually evolve. I think we're going to have less recurrences as we bring some of these elegant drugs that we're now finding can actually trespass the central nervous system, blood-brain barrier, and being smart enough to know that we can't get comfortable after 2 years and 5 years, with some disease subtypes like HER2 or even estrogen positive breast cancer. We have to be wary even 10 years down the line and 12 years down the line and 15 years down the line, because we've changed the natural history of the disease in most patients by either eliminating it, yay, or perhaps changing the way the disease is going to behave. And going back to what Jamie said, that cell that figures out a way to escape treatment and lie dormant until something may trigger it. So that's a huge topic in and of its own. And I will say, all important because of that, to keep your healthy parts healthy. Those are going to be your best friend in the setting of a recurrence, not what I have available for the patient, not what my research colleagues like Jamie have available for the patient, but how your body will be healthy enough and protect you in the setting of recurrence, not only to keep you vibrant during treatment, but allow you to be as healthy as possible for future treatments. And I think, Jamie, you touched on it as far as side effects down the line. We now have cardio-oncology, a subspecialty that has exploded because of the HER2 new therapies that now follow patients, cardiologists who specialize in that group of patients that have been exposed to oncologic treatments that may have a potential cardiac risk down the line as patients get older. Now our patients are living so much longer. We are practicing so much older. And we are going to see changes 10, 20, 30 years down the line that are so important, especially in those patients who have been diagnosed in their 20s and 30s and 40s that are still going to be hopefully healthy in their 70s. 70s is not our mother's 70. I say over and over again, Colleen, remember, I'm the new 55. So, we have subspecialties now that look at the skin. We understand a genetic mutation, what it may mean in different settings, not only in screening and early detection and risk reducing maneuvers, but also in treatment maneuvers. So yes, I'm a big believer that women should be genetically interrogated because there may be something available for them down the line. We are running out of time. Jamie, anything to add to this?
I think it's been a pleasure to chat with you. I think really the most important thing that I think about when I think about molecular profiling in this setting of breast cancer patients is just making sure that you have all of the information because
or what's available today. We
right.
may have more information, and we always have to be savvy enough to do a continued interrogation down the line, because what we found today may be very different 2 years from now, and we may have more available 2 years from now. I'm sorry, I interrupted rudely.
No, 100%. The tumor changes and you need to know what it's doing now to know how to treat it now. But I think having that information just really helps a patient to feel confident in the decisions. And I think there's nothing worse than feeling regret, like, what if I would have done this? What if I would have done that? Should I have checked this? And so having all of that information can really just sort of change the mindset of how you approach your treatment. And I think that that's super important.
Jamie, I just hope that you will be willing to come back on this forum.
Anytime.
Oh, wonderful, wonderful. Colleen, I'm going to kind of, abbreviate your thunder, because I want to bring to the audience a question that I received yesterday. And it states, is there any current research on having soy in the diet of breast cancer survivors? That's the key. Is there a difference between processed versus unprocessed soy products? I can actually answer that question and tell you, for a long time, soy was a big no-no. It's a phytoestrogen. We didn't know how patients diagnosed with breast cancer or who have survived their breast cancer might be triggered. We know now that that's not true, that there is safe soy amounts to take, and there's research that's come out of some of the Asian countries. But I'm giving this information to kind of hook the audience. Next month in March, we're going to have Neil Iyengar, who's at the very forefront of research and is a practicing medical oncologist at Memorial Sloan Kettering Cancer Center, who runs a lab who has looked at obesity and breast cancer, estrogens and breast cancer, and soy and breast cancer. And he's not going to come on alone, although I think that I probably should have him alone. The counterpart is not going to be just Neil and what he's going to teach us. We're going to have Jean Carter, who's an incredible PhD, who is the chief of the sexual health department at Memorial Sloan Kettering Center, Cancer Center. And we're going to talk about healthy sexual living. It doesn't have to do just about intercourse, although we'll talk about that. But also, what about hormone replacement? So we have a terrific program coming up in March, on March 15th. We'll be joined by Neil Iyengar and Jean Carter. I can't thank you enough, Colleen, for taking your time after seeing 20 patients today in clinic. Jamie, thank you so much. I thank the audience. I thank the foundation at New York Oncology Hematology for supporting this. I thank our donors and Stacy Fisher Rosenthal. You've been a huge donor of this program year after year. And everybody, just be aware that up in Albany, we have a state-of-the-art imaging center right now called Akira. Look us up online, and we will all see you next month. Good night, everyone.
Thank you.